This short video will discuss the article by Cassell, Principles of the Belmont Report Revisited. There will be an associated video dealing with the Shelton article, The Harm of First Do No Harm. But it is again helpful to have a historical context when reading the article by Cassell. Both this article, Cassell and Shelton, were written in the year 2000, but to different audiences and for different purposes. So please review the Exam 1 study guide as part of your preparation and review of these two articles. These articles offer understanding of principles and perspectives that provide a foundation for future ethical discourse. You see some biographical and web link information about each of these two authors. I hope that you will take a few moments to read more about them. Each has made significant contributions to the discussion about bioethics. We have mentioned the Belmont Report previously. It originally was designed only to be applicable in research with human subjects, but it has become a guide for all interactions between researchers and healthcare providers when dealing with individuals in any setting. I hope that at some point you review the two web links there to have more information about the Belmont Report. This report identified the three principles of ethical treatment of subjects. The first principle was respect for persons, which is interpreted as respect for the individual's choice or right to choose, which we call individual autonomy. The report recommended that in all healthcare-based situations, the individual must be allowed to exert autonomy to decide yes or no for himself, and those individuals with decreased autonomy or decreased cognitive ability, and also those who were identified as members of a vulnerable population, are to be protected and must have extra or special considerations in terms of individual autonomy. It is this report that first classified vulnerable populations: women, pregnant women, children, students, those who are mentally ill, and prisoners. These groups were to be accorded special, more in-depth instruction and protection. The second major principle identified was beneficence. That is, researchers and healthcare providers are under obligation to provide care or engage in activities that result in benefit for the individual. If full benefit could not be ensured because of the nature of the research or of healthcare situations, then the primary goal was to be maximizing benefit and minimizing possible harm. Implicit in this context is that the provider should strive to do no harm. However, we know from previous readings that it is not possible to benefit all the time for all involved, and there is some harm associated. The Shelton article will provide additional insight into that concept. Another major principle that must guide any intervention is that of justice. Justice was informally defined as equal treatment or equal access to services, and we've also discussed that because of limited resources or limited access to resources, there needs to be criteria upon which to determine who receives resources. The Belmont Report suggested 5 different considerations depending on the situation and the resources involved, and you will see them listed in the slide. All share equally or divide resources according to individual need, allocate resources according to individual effort, allocate according to societal contribution, or allocate according to merit. As a society, we allocate resources using each of these criteria at different times and in different ways. The key in understanding justice from an ethical perspective is to understand which criterion is most relevant in different situations. When you prepare to study the Cassell article, I would encourage you to read the 2 case studies at the beginning of the article and the final case study at the end of the article. Read those first. They will help you understand how the principles are upheld and understood within clinical situations. Cassell essentially discusses how the critical principles have been applied to healthcare and healthcare ethics, and he also provides an historical context of societal contextual influences that have significantly influenced an increase in the numbers and complexity of bioethical dilemmas. These are similar to those mentioned previously in this class, so by now you should have a firm contextual understanding of current and historical influences. Technological developments led to increased cost of new therapies. Chronic disease has become the prevailing type of health problem, supplanting infectious diseases and even accidents as the most common serious health problem. And with these changes, there have been associated changes in the relationships between the person and the provider in terms of a more patient-centered and consumer-oriented healthcare relationship. With the resultant emphasis on beneficence from the Belmont report and these new technologies, several changes have evolved. The concept of doing good has a different meaning, a different connotation than it originally did in 1978. There has developed a concept that Cassell calls disembodied benevolence. Cassell describes this as care and cure devoted to parts of the person rather than the whole person. The technology that is developed required very specialized knowledge, so specialists for the heart developed, specialists for the lungs developed, specialists for the stomach developed, neurologists, specialists for the brain, specialists for the bones developed. Each organ required a specialist. In addition, the good for the whole person became, I can only do good for one organ. The problem is that the specialist did not talk about other organs, so no one really cared about the person. Healthcare providers only addressed one organ. But another byproduct of this was the practice of what Cassell calls cafeteria medicine. The rise of advertising on TV and the internet resulted in individuals wanting what was seen in the media. Starting with the advertisement, well, ask your doctor if you are a candidate for a particular drug. This resulted in patients seeking care of TV implied ailments and demanding treatment because someone on TV said it helped them. But coupled with social behavioral changes came a significant increase in the cost of services. The healthcare system moved to a single-use, one-dose disposable plastic everything. Instead of considering benefit and burden to the patient, healthcare agencies began to consider cost burden for the agency and sought to limit expenses even as there was an increasing demand for expensive services. Cassell also provides insight into some sociological changes. The change that resulted in the person becoming the patient rather than the patient seen and treated as a person. And those are different concepts. The sociological and cultural movements to better integrate groups who had been marginalized in healthcare, groups such as women and ethnic minorities, gays and lesbians. Some other groups also led to changes in how these individuals demanded to be treated. In the 1960s to the 1980s in America, there was perfect weather. Healthcare was great. You see the conditions identified on the slides. There was a fall in death rates. Antibiotics were available for infections. Effective anesthesia for surgery, respiratory ventilatory support. There was improved nutrition, scientific advances in diagnoses. It was perfect weather in healthcare, and everybody wanted the best of everything. Then in the late 1980s and early 1990s, the perfect weather devolved into a perfect storm in healthcare. Autonomy was seen as an inalienable constitutional right, and whatever one wished for was demanded in healthcare. If there was a new diagnostic procedure, it must be done. If it wasn't done, litigation became common, and the idea and perceived need of defensive medicine greatly increased. It quickly became a nightmare and out of control, and that is really the basis for some of the comments by Galen, Callahan, and Childress and Fletcher that you have read previously. In summary, you see the three major changes over time in views that evolved from the Belmont report. Healthcare moved from caring for the individual to care for a body part. Respect changed from a sincere concern for the individual to demand that whatever the individual requested had to be honored regardless of cost or benefit. Justice, seen as fair and equal treatment, was not previously seen as a critical consideration in healthcare, but was now seen as a mandatory consideration, and healthcare became a commodity or resource which must be allocated or made available based on justice considerations. So Callahan is encouraging bioethicists to consider the role of the provider. Should the provider be responsible to the individual patient or to society? That is the primary focus protection and benefit for one, or protection and benefit for the many? Should decisions be made based upon economic considerations solely, or should the system focus on the individual person? And Cassell is emphasizing that these questions should be discussed and balanced with equity and efficiency, and we are still grappling with this issue. This concludes the short video dealing with the Cassell article. Please also review the article by Shelton on the harm of doing no harm.